Welcome to the deep dive. Today we're really getting into the foundations, the bedrock of dental implantology. We're talking about comprehensive implant site preparation in the mandible.
That's right.
Just picture a dental professional, looking at a jawbone that's maybe not quite ideal and figuring out how to sculpt it, prepare it, make it the perfect base for a new tooth. It's really intricate stuff.
Often in quite challenging situations, too.
Exactly. And we've pulled together a really solid stack of sources for this, including a very detailed chapter that gets into all the little details.
And our goal here today, for you listening, is really to boil down the essential knowledge. We're looking at all the different ways, the cutting-edge techniques that professionals use to get that jawbone ready.
It sounds like a field with a ton of planning.
Oh, absolutely. Intricate planning, sometimes surprising solutions. Every single site, it presents its own unique puzzle. Very tailored approaches are needed. We're here to help make sense of that puzzle.
Okay, so let's start with this foundational idea. You mentioned that rebuilding the mandible, whether it's just one missing tooth or the whole set, it all stems from what the patient actually needs restoratively, right? The final teeth.
Precisely. That's the core principle. You don't just, stick an implant where there happens to be bone. No.
Yeah.
First, you figure out what that final smile, that final function should look like.
Okay.
And then you build the bone structure needed to support that specific vision. Generally, we think about missing teeth in categories. You've got single teeth missing.
Right.
Multiple teeth, maybe 2 to 6 right next to each other. Or what we call a free end saddle, that's teeth missing at the back, nothing behind them for support. Or an anterior saddle, missing front teeth. And then, of course, fully edentulous, no teeth at all.
Yeah.
That can range from, someone who just had teeth extracted to cases with really extreme bone loss over many years.
Oh.
And for pretty much all of these scenarios, the natural jawbone often has, let's say, hard tissue findings that are not ideal.
Not ideal. Okay.
And you have to deal with those issues. But, and this is really the crucial point, that the desired implant treatment plan, the final goal, has to be locked in before you even think about modifying the bone.
Before touching the bone at all.
Exactly. The main goal is efficiency. Use the fewest implants possible to get a successful, stable, final result.
That makes a lot of sense. So, keeping that big picture in mind, it sounds like the strategies must be totally different for just a single missing tooth compared to, say, a whole arch.
Oh, completely different worlds.
You mentioned things like minimal flaps, minimal bone grafting, sometimes connective tissue grafting. This is where it gets really interesting, isn't it? Because a missing front incisor is it's fundamentally different from a missing back molar.
Absolutely.
Let's zero in on those mandibular incisor sites first. They sound notoriously tricky. What are the main headaches for clinicians there?
Well, the dilemmas really come down to 2 main things. One, there's often very, very little space to actually place the implant.
Right, they're narrow teeth.
Exactly. And 2, the bone mass in that specific area is often reduced. There's a critical rule, sort of a dictum for surgeons.
Yeah.
You need at least 1 millimeter bone completely surrounding the implant, circumferentially.
1 millimeter all around.
That's the minimum for stability and for the bone to properly integrate, to fuse with the implant. So think about it. For a tiny 3.7 millimeter implant, the site itself needs to be at least 5 millimeters wide.
Okay.
Or for a more standard 3.5 millimeter implant, you need 5.5 millimeters of width. It doesn't leave much wiggle room.
So that precision, that really tight space, what does that mean practically for the patient or the clinician dealing with that front tooth region?
Well, it means these sites very often have minimal bone on the facial side, the lip side. They might have a lack of good gum tissue, what we call a mucogingival deficiency. And the roots of the neighboring teeth can be incredibly close. And all that leads to some really tough decisions. Sometimes conventional dentistry, like a bridge, might be the better option. Or clinicians might consider what some sources call a more aggressive approach. Which could mean removing adjacent incisors, even, perfectly good teeth, just to create enough physical space for an implant.
Wow, okay.
Sometimes we even see cases where 2 missing teeth are replaced with just a single implant because of space limits. Or maybe a 3 or 4 tooth bridge makes more sense, often combined with GBR-guided bone regeneration.
That's adding bone.
Essentially, yes. Creating a protected space at the time of extraction or later for new bone to grow. One important warning, though. Immediate loading, putting the final crown on right after placing the implant, it's pretty risky in these compromised incisor spots.
Why is that?
High risk of the implant failing to integrate properly early on, especially with those smaller, sometimes one-piece implants. So the ideal timing. Often it's placing the implant when the tooth is extracted. If there's significant bone loss on the facial side already, using a staged GBR technique, let the bone heal first.
And then maybe add gum tissue grafts later.
Exactly.
Right.
Connective tissue grafts can be added to improve the gum health and aesthetics around the implant.
Okay, so let's shift back a bit away from the very front. What about the canine bicuspid zone, the pointy tooth, and the ones just behind it? Is there a bit more breathing room there? You mentioned it often allows for immediate placement when the tooth comes out.
It definitely can be less complicated, yes. When you take a tooth out, if the remaining socket defect is bigger than about 3 millimeters, putting some bone graft material right into the socket, intrasocket grafting, is generally a good idea.
Why is that? Is it for the implant?
Well, not strictly necessary for the implant itself to fuse with the bone, no. But it's really helpful for maintaining the width of the jawbone ridge there. Otherwise, that bone tends to shrink inwards, centripetally, we call it. And that can leave less bone covering the outer surface of the implant later on. This is especially true in the bicuspid area, which can naturally be quite narrow horizontally.
Makes sense.
Now, if the tooth's already been gone for a while and the site has healed, GBR can still be used for smaller bone defects, those little deficiencies.
And if the whole ridge is narrow?
If the whole ridge, the alveolus, is too thin, you can do something called alveolar split grafting. Think of it like carefully splitting the bone lengthwise, opening it up like a book almost. You need a minimum width of about 4 millimeters to do that safely, aiming to create about 2 millimeters of facial bone plate for the implant. There's also another technique called the book flap, an osteoperiosteal flap bone, and it's covering tissue together. That's another option for widening things out.
Interesting. So let's move further back now. What does all this mean for molars, way at the back of the lower jaw? You said earlier these are generally not great spots for immediate placement unless you use really big implants. Why the big difference back there?
Yeah, the main drivers there are safety and the local anatomy. In the lower molar region, there's a really critical safety rule. You absolutely have to stay 2 or even better 3 millimeters above the inferior alveolar nerve.
That's the big nerve in the lower jaw.
That's the one. It runs right through there and provides sensation.
Yeah.
If you disturb it, you can cause numbness. So the position of that nerve basically dictates how much vertical bone height you have to work with for the implant and any grafting you might need.
Okay, nerve safety first.
Absolutely.
Yeah.
Then the other key issue is the buccal plate, the bone wall on the cheek side. If that plate is nice and thick, substantial, then yes, you can sometimes place very large diameter implants. We're talking 7.5 to maybe 9.0 millimeters wide, often with little or no bone grafting needed.
Because they just fit.
Essentially, yeah. They fit within the existing bone without needing much help. But for the more standard implant sizes, say 4 to 6 millimeters in diameter, bone grafting along with a resorbable membrane is usually recommended. And typically that's done as a staged approach.
Meaning graft first, wait, then implant.
Exactly. Let the graft heal and mature before you place the implant into the newly formed bone. Now, if you're dealing with a molar site that healed long ago, well, you often find deficiencies, either in width or height, or both.
Right.
If it's mostly a width problem, a horizontal deficiency, you can usually still place the implant, maybe positioned a bit more towards the tongue side than GBR is used just to kind of plump up the contour on the cheek side.
Okay.
But if you have significant vertical deficiency, meaning you've lost more than, say, 3 or 4 millimeters of bone height, then you really need vertical augmentation, building the bone back up.
And how do you do that?
Several ways. You could use block grafting, maybe with BMP2, which we'll talk about later. Or there's something called a sandwich osteotomy graft.
A sandwich graft.
Yeah, basically cutting the bone segment horizontally, lifting it up, and placing graft material in between like a sandwich filling. The sources mention this one is often the simplest option for moderate vertical gain, easily getting you maybe 5 millimeters of extra height with relatively little discomfort for the patient.
That's quite a gain. So connecting this to the bigger picture then, it seems like when someone loses several teeth in a row, multiple contiguous teeth, you often end up with both vertical and horizontal bone loss, right? Combined deficiencies.
That's very common, yes.
Which must demand even more extensive rebuilding, more complex augmentation strategies. How do clinicians scale up their solutions when facing these larger segmental or even full arch defects?
You're absolutely right. The complexity definitely ramps up. Let's take anterior segmental defects, first missing several front teeth in the lower jaw. We tend to classify the bone loss here. Mild deficiency might just need GBR. Moderate deficiency. Now you're looking at things like block grafting, maybe interpositional techniques where you place bone between existing bone segments, or using titanium mesh to contain the graft.
Right.
And then for severe bone loss, severe lesions, that often requires larger block grafts, maybe taken from the patient's hip iliac corticocancellous grafts, or larger titanium mesh structures, frequently boosted with morphogens, those bone growth-inducing substances.
And if the jaw is actually discontinuous, like a piece is missing?
Yeah, for complete loss or discontinuity, maybe from trauma or surgery, the options get even bigger. Free fibula grafts, using bone from the leg, iliac bone grafting again, or BMP2 procedures, depending on how long the missing segment is.
Wow. What about the more common situations, those moderate to severe defects, maybe from gum disease or injury?
Right, those are probably the most frequent, often from trauma or long-term periodontal issues. When you've lost, say, 5 millimeters of vertical bone height, maybe even up to 10 millimeters, that sandwich osteotomy bone graft we mentioned becomes a really key player again, especially in the front.
The alveolar lift.
Exactly. It's essentially an alveolar lift. You might lift the segment up, say 4 millimeters, and you can sometimes combine that with an internal alveolar split to widen the narrow ridge at the same time.
How's that done?
The access is usually through the vestibule, the space between the lip and gum, and often using piezosurgery, those ultrasonic tools for very precise bone cuts. Then you place your graft material, your inlay material, into the gap created. And usually a small bone plate is needed to hold that lifted segment in its new, more facial position because it naturally wants to drift back towards the tongue.
Fascinating. Okay, let's swing back to the posterior again. That free end saddle scenario in the back of the lower jaw. I can imagine this is super common. Someone has maybe 6 or 8 solid front teeth, but nothing behind them.
Extremely common scenario, yes.
And full fixed bridges spanning that whole gap might not be ideal.
Right. And these posterior sites, these free ends, they often show significant bone atrophy, meaning shrinkage, and again, very close proximity to that inferior alveolar nerve.
So nerve safety is paramount again.
Always back there. Now, block bone grafting may be using bone from the patient's own jaw or hip. It's definitely been a common treatment. But interestingly, the sources we looked at really emphasize that block grafts in this specific location tend to have a high rate of resorption. They shrink quite a bit over time.
So you have to plan for that shrinkage.
You do. The recommendation is often to overbuild the graft initially, knowing that you're going to lose some volume. Newer GBR strategies are also used frequently here, sometimes using high-profile supports like special screws or even temporary implants just to hold the shape while particulate graft material turns into bone around them.
Maintaining the space.
Precisely. There's also a newer idea called the bone wedge technique. Small wedges of the patient's own bone are inserted into the base bone, sticking up quite high, then covered with more graft and a membrane.
Interesting.
And that curved sort of smile-shaped sandwich osteotomy we talked about, that can also be adapted quite well for these posterior segments too.
Okay, now for the really big one. Full arch reconstruction. Replacing all the lower teeth. You hinted earlier there's some controversy here. What's surprising, especially for patients thinking about a full fixed solution?
Well, what's really quite striking, I think, is that the early methods using large iliac block grafts, taking bone from the hip, to rebuild the entire jaw height. While those techniques historically show good success, even looking at 20-year results, they've actually become an infrequently done procedure today.
Really? Why is that?
Well, it raises a really important question that's being debated now. This idea that maybe severely atrophic, completely edentulous mandibles might not require extensive vertical bone grafting at all, especially perhaps in older patients.
So what are the alternatives then?
We're seeing different approaches emerge. Things like using very short implants, sometimes even designed to slightly perforate the lower border of the jawbone. Or placing implants without any bone grafting for fixed hybrid bridges.
Like the all-on-4 concept.
Exactly, that type of thinking. A prime example mentioned is the V4 technique. Using just 4 implants, strategically placed in mandibles that might only have 5 millimeters of bone height remaining, and often allowing for immediate functional loading, getting teeth on quickly.
That's a huge shift from massive grafts.
It really is. Other alternatives exist too, though perhaps less common. Total edentulous jaw distraction, where you surgically cut the bone and slowly stretch it over time to stimulate new growth. There's tentpole iliac grafting done from an approach underneath the chin. Nerve transposition, where that inferior alveolar nerve's front loop is carefully moved back to make space for more posterior implants. improving the spread.
And for discontinuity, like after cancer surgery.
Right, for those major defects, the big guns still come out. Free fibula grafts, iliac grafting, and increasingly using BMP2 combined with allograft bone inside confining mesh cribs. All have shown success.
Okay, you've mentioned BMP2 a few times now. It sounds like this is where things get really exciting. The sources suggest it's causing a significant paradigm shift in how we approach lower jawbone reconstruction. Why is BMP2 such a potential game changer? What does it mean for patients?
It's considered highly desirable for a couple of key reasons. Firstly, as we touched on, harvesting the patient's own bone, whether from inside the mouth or from the hip or tibia, it inevitably causes a certain amount of morbidity.
Meaning another surgical site, more recovery time, potential complications.
Exactly. Pain, healing, risk at the donor site. BMP2 potentially avoids all that. Secondly, and this is crucial, traditional alternatives like xenografts, animal bone, or allografts, human donor bone, even when mixed with growth factors like PRP, they just have not been as successful at forming de novo bone as has BMP2 clinically.
De novo bone, meaning new bone.
Brand new, patient's own bone, grown right there in the site where you need it. BMP2 is a signal protein that instructs the body's own cells to become bone-forming cells. It actively grows bone, rather than just acting as a scaffold or filler.
That sounds revolutionary. Is the science backing this up?
Oh, the research, especially the preclinical animal research, is incredibly compelling. There are studies in canine models, for instance, showing that when BMP2 was placed under a barrier membrane around tall, high-profile implants, it consistently made bone.
Consistently?
Yes. Another study used a calcium phosphate cement mixed with BMP2, this time without a barrier membrane. And it still showed really robust bone formation, even greater bone density.
Impressive. Does it integrate well?
That's key, isn't it? One study specifically looked at that and found no difference in osseointegration content. About 55% bone-to-implant contact between the bone induced by BMP2 and the dog's original native bone.
So it behaves like normal bone once formed?
It appears so, and may be the most critical finding.
Yeah.
Another canine study placed high-profile implants, grafted them with BMP2, restored them with teeth, and left them functioning in the mouth for a full 12 months.
And the result?
They found the bone level around the implants was perfectly maintained, with no discernible difference between native and BMP2-induced bone.
Wow. That really is proof of principle, isn't it? It shows it's possible, potentially, without having to resort to the tibia or ilium for graft material.
Exactly. It genuinely changes the landscape. It could make these complex bone rebuilding procedures significantly less invasive, less morbid, and maybe more accessible for a wider range of patients.
So where are we now with it clinically?
Well, the current focus really is on clinicians carefully investigating and validating the best systems to use in practice. Which implant systems work best with it? What's the optimal way to deliver the BMP? How do we best maintain that regenerative space morphologically while the new bone forms? It's about translating that solid preclinical science into reliable clinical protocols, but it marks a huge step forward.
Absolutely huge. Wow, we have covered an incredible amount of ground today. A real deep dive from the tiny, tricky details of a single front incisor all the way to these massive full arch reconstructions and now potentially growing bone on demand.
It really showcases how far the field has come and just how personalized these solutions have to be.
Definitely.
And I think the core message for you, the listener, to take away remains this. Yes, the surgical technique has to match the defect you're treating. But the decision about where to place implants and if grafting is needed, it's always ultimately driven by the overall restorative plan. What are the final teeth going to look like and how will they function?
Right.
And what's exciting now is that those restorative plans themselves are becoming more efficient, often using fewer implants, placed more strategically. That sometimes lets surgeons completely avoid the most compromised bone areas, meaning they could potentially sidestep the need for really extensive bone grafting altogether.
Which ties back to those non-grafting approaches like the V4 you mentioned. It's also so important to remember, isn't it, that treatment is always tailored to the individual. Especially for elderly patients, maybe someone less able to tolerate major surgery. Simpler options like implant-supported overdentures or maybe those non-grafting all-on-4 type techniques might be a much better fit even if there's significant bone loss.
Absolutely crucial point. Patient factors are paramount. And maybe the final thought to leave you with on the technology side. Bone morphogenetic grafting using proteins like BMP2. It's really no longer a dream of the future.
It's here now.
It's a present reality. It's underpinned by solid, well-documented preclinical science, and it's actively changing what clinicians can offer their patients in dental reconstruction.
Which leads to a fascinating question to ponder. As we get better and better at regenerating bone, perhaps more easily and reliably, how might our whole concept of what's natural versus what's restored start to shift in the future of healthcare? And what incredible new possibilities does that open up for patients all over the world? Something to think about. Thanks for joining us for this deep dive.